Very good evening, ladies and gentlemen. First of all, I would like to thank the Providence team, especially led by Dr. Matthew, Dr. Chichu, and Dr. Deepa. I think the topic for today's discussion in the foot care wing is advanced wound care and what is practically available. We know in our day-to-day practice, we all have problems when we come across a complicated diabetic wound or a chronic diabetic foot ulcer. There are a lot of options, but how we should choose the options in the current scenario or in the era of nanoparticle medicine and evidence-based medicine, which agent we should be choose. That is one important thing that we'll see in the next 12 to 15 minutes. The famous article which came in way back about 10 or 20, 15 years back in Lancet, it says that every 30 seconds a limb is lost somewhere in the world as a consequence of diabetes. It itself says the issues associated with diabetes or the magnitude of diabetic foot issues. So when we come across a diabetic foot, whether our focus is only on dressing the wound or managing or healing wounds. So if these are the 3 points we are looking, then we are into the wrong direction. I think we have to be careful that we should focus on the prevention of diabetic foot ulcers also. This is the burden of diabetic foot ulcer because any person who is having a diabetes who have a 25% chance of developing an ulcer in his lifetime, and this is one of the most leading cause for the non-traumatic limb amputation. Whatever available modality of treatment is there in our armamentarium, but most of the time the reality of diabetic foot disease, as I have shown in this diagram, there may be photo already, there may be an amputation and the patient may be going to another amputation sooner or later. So these are the factors which influence the wound healing, especially the level of the oxygen, that is a local tissue oxygen saturation is one of the important factor. Then again, the tissue factors which get deranged in diabetes, like there will be deficiency of damaged matrix or metalloproteins, the inflammatory environment will be totally changed, and important is the biofilm formation and growth factor deficiency. So all these factors will contribute to the wound into a chronic wound, and we have to choose the agents which can overcome these factors which detrimental for the wound healing. Then if we overcome that, we will be able to give a positive outcome to the patient. The simple meaning of advanced wound care, if any ulcers which does not adequately heal to the standard modality which is available, we have to go for the options, newer option that's included in the term of advanced wound care. Before that, we have to look for a triangle assessment of wound, especially the wound bed, the edges of the wound and the peri-wound skin. This is very, very important because the types of the tissue or the level of the exudate in the wound bed is very important for choosing either the local agent or any machine if you want to apply, or if you want to give antibiotics also. It is very, very important, and it gives a clue about which type of debridement you should use when a wound come to you. So the triangle of wound assessment is very important. As I said, whether the base wound is a necrotic or a sloughy kind of a thing or granulating, because based on this appearance, you have to choose the ointment, whether it is gel or whether it is spray or whatever it is available. Based on the local tissue appearance only, you have to select the agent. So this is whether it is a surrounding area is a macerated wound, or whether it is a dehydrated, whether it is an undermined, or it is a rolled edges. All these factors which determines the selection of agent in your day-to-day practice. So once you had made the wound assessment, your management plan is ready. So your aim is to provide a minimal tissue loss, and as soon as possible the wound should be approximated and the wound edges should get approximated, and there should not be any recurrence of wound. That is what our aim when we are treating any diabetic foot. These are the armamentarium which is available for wound healing. Dressings, various dressings are there, the devices, because even if we dressing itself may be a topic for one presentation, devices are there, the drugs are there, surgical options are there, especially the interventional surgeries are there, biologics are there, combination therapy is also there. But you have to think, is there any potential single magic bullet for diabetic foot healing? If you think so, then you are wrong. There is no single options. Because wound healing is a complex, you have to assess the systemic and the metabolic and the local factors. You have to go for a proper glycemic control, nutritional control. Along with that, you have to give a local factors which promotes the wound healing. These are the conventional management. The gold standard is offloading of pressure. You have to keep the wound moisture levels correct. You have to keep it clean. You treat the infection. If there is ischemia is there, you revascularize. But this is always enough. If it is always enough, why we'll end up in amputations? That's what we have to think. The current dressing categories, a lot of things are there available in the market. You and me know that. But based, as I said, based on the assessment of the wound, you have to choose the ointment, whether it is an absorbent dressing or the alginate, or whether it is foams, hydrocolloids. A lot of options are there, but you have to choose according to your experience. These are the advanced wound care options, which I'll highlight because of the limited time. The collagen and the biological dressings, the biological skin equivalents, the platelet-derived growth factor, the platelet-rich plasma, intermittent pneumatic compression therapy, the negative pressure wound therapy, and HBOT. The items which I have shown in blue, because that's what I am using it in my day-to-day practice. So I'll be concentrating on especially that things, especially the bioengineered tissues, the negative pressure wound therapy, HBOT, and one modality which is in the horizon in the near future is stem cell therapy. The collagen products, as you all know, that it is available as powder particles, it is available as gel forms, pads, and because the DFU has known to have a prolonged inflammatory response and irregularity in the extracellular matrix. So collagen dressings will support and creates changes in the extracellular matrix that regulates the extracellular components, and it makes the chronic wound towards the closure. So collagen promotes in the synthesis of cellular membranes. These are the available bioengineered dermal substitutes or equivalents, especially the Epligraft and the Dermagraft. Epligraft is made from the neonatal fibroblast. It is scaffolded to a type 1 porcine collagen and placed on the wound. And the human fibroblast derived dermal stress substitute is a Dermagraft. It is again composed of fibroblast and extracellular matrix, and the soft portion of these available portions will be placed on the wound surface, and this will promote the wound healing by angiogenesis or newer tissue formation. The growth factors, this is the one growth factor, the plermin, the becaplermin is accepted by the American Diabetes Association in the management of diabetic foot ulcers. And this topical agent stimulates and supports the wound healing process. The studies have shown that it promotes a 43% of greater incidence of healing, especially in neuropathic ulcers, than a placebo thing. NPWT, or it's well known as a VAC therapy. It's an option for treatment of complex wound, especially the amputated stem, non-healing amputated stems. It consists of a polyurethane sponge form. You can see from the diagram itself, it has got adhesive cover, fluid collection system, and a suction pump. It creates a subatmospheric pressure in the system, and this subatmospheric pressure will help in controlling the edema, thereby promoting the microvascular circulation that is very important for the healing of the wounds, and it promotes the granulation tissue formation also. But you have to be very careful. The selection of the patient is very important. If there is any fistula or connection of the wound with any cavity, you should not use that, and it will help in giving the you can remove the slough also after application of this thing. PRP, I don't have too much of experience, but the literature says PRP, and nowadays left and right PRP is used for a lot of other indications also. But it says that it consists of cytokines, growth factors, so it's also helpful in healing the wound because it modifies the molecular and cellular functions. And this study shows that 2 years back it is published, the topical application of platelet-rich plasma for diabetic foot ulcers has shown that the healing rate was significantly faster when PRP is applied compared to the controls. This is one interesting thing which is available if you apply this dressing. It's as I said, the nano capsules. If the nano capsule will break and it will give a fluorescent color if there is infection in the wound is there. So if the color turns, then you can think that there is infection is there, and it helps to avoid unnecessary use of antibiotics for the patient. This is epidermal cell grafting. It's somewhat similar to the skin grafting, split skin grafting. You can see some dots are there in the thigh portion from the donor side is taken. This is how the multiple small thing will be taken, and it will be placed on the site where you are desired. It's something like a sticker with a superficial skin folds. very easy procedure, 30 to 35 minutes it will be completed. And one advantage comparing with the skin grafting is there is no donor site wound, and like this the wound site will be like this, and you can apply it as a along with the thing. Then chitosan, which is a biocompatible molecule, it is a lot of researchers are going in the field of chitosan, and because it has got a non property like antimicrobial property, it stimulates the dermal fibroblast. A lot of research are going in Chivanda, especially the Sri Chitra Tirunal Institute, which is situated at Pujapura. This is a transdermal cutaneous oxygen therapy, very effective. It is once you apply, you can keep it for 10 days to 2 weeks. It improves the local tissue oxygenation, electrical stimulation. The transcutaneous electrical neural stimulation is used, but a few places it are used for neuropathy also, but the results are variable according to the RCTs. Maggot debridement, it's not a new modality, but you can give the tiny surgeons a chance to get rid of this soft tissue, which is given in the picture, especially like dirty wounds. You can make a pattern of the wound and place this gauze bandage for draining. These are very important. Certain drugs you have to be careful, which delays the wound healing, especially the beta blockers, immunosuppressant drugs, and steroids. When you are giving, you have to be very careful. Nanofibers, because the era is of nanotechnology, you can use it as a scaffold which is attractive to the healthy cells and form the adjacent tissue following creation of an acute wound, which will help. This is the upcoming thing, the stem cell therapy. I don't have too much of experience with stem cell therapy, but the literature says you can give the marrow-derived mesenchymal stem cells, which will be mobilized to the peripheral circulation, and it will differentiate into skin cells, and it will help in wound healing. This is the nanogen actigel. It is obtained from a plant extract. It is very useful as per the literature says. You can use a silvergen spray is there. This is again very good in preventing the infection and helps in promotion of granulation tissue. This is what my bread and butter, that is a hyperbaric oxygen therapy, which involves the intermittent inhalation of 100% oxygen in a pressurized chamber above 1 atmospheric absolute. You all know that sea level pressure is 760 millimeters of mercury. Based on the gas laws, when you increase the pressure high, the dissolved amount of oxygen will be increased in the plasma. That is what the primary aim of the therapy, the physiology of HBOT. The oxygen dissolved in the plasma, when you go up to 2.5 atmosphere, will increase to 5.62 from the resting of 0.32%, and this is more than enough for an ideal delivery to the local tissue, and it will overcome the hypoxia. All the tissues will get supersaturated with oxygen, and it will stimulate the cellular function to happen. And you can give it by monoplace or a multiplace chamber. Multiple persons can be kept at time. So when you give more oxygen dissolved in the tissue plasma, what will happen is the oxygen transport will be increased. There will be reduction in the edema, and there will be epithelialization will be promoted, angiogenesis will be promoted, and oxygen itself has got a bactericidal and bacteriostatic action. This is the result of what we had in our last means 2 years, initial 2 years. You can see the diabetic ulcers is about a 45% average on both phases of study. Number of patients was average about 210 for both the phases. The Wagner stage, the leading stage is 39%, is at stage 3. Stage 4 is either a part of the limb is what you call gangrenous. Average number of sessions was 23 for both the phases. You can see the TCPO2 is increased from the baseline of 30 to average 30 to 35 to 58 to 60. That means even an increase of 20 millimeters of mercury had proved very effective, and the complete healing was observed in about average 70% of patients. This is what the need of the hour. You can use the HPOT effectively. The growing awareness is needed. These are the few patients. I don't know whether I'll get a time. 1 more minute is left. So these are the few complicated cases. I will show how we are treated with HPOT. Heel pad gangrene, beautiful scar is there. This is again a post-amputated stump, advised for a BK amputation. The patient is doing well for the last 1.5 years. You can see a beautifully healed wound is there. This is again a vasculitis wound, very difficult to young girl, but we have to go for a small skin graft also, but the wound has completely healed. So in wound care, your goal is to healing, get the healing as soon as possible, and you have to prevent the recurrence. And evidence is very important, but you have to choose based on your experience also. So synergistic wound healing is very, very important when you manage chronic wound. You can use modern dressings, you can use antibiotics, you can use VAC, you can use HBOT. And synergistic wound healing simply means that you can use two or more advanced wound care technologies to improve the wound healing. So to conclude, it is a burden of complex, expensive thing. Advanced wound care technology should be utilized based on the clinical findings and your individualized care planning and individual experience. So always remember, as Paul Brand said, the pathway to amputation is littered with bandages and dressing, which have deceived both the doctor and patient into thinking that by dressing an ulcer, they were curing it. Thank you all for your valuable time. Once again, thanks for the Providence team. Have you all a great evening. I hope I finished in time.